Hello, everyone, and welcome to the MDH Stroke Program Monthly Education Series. With May being Stroke Awareness and Mental Health Awareness Month, we wanted to shine some light on important resources for patients and their mental health following a stroke. We are excited to have Dr. Greenberg with us today, who is a clinical psychologist practicing at Park Nicollet Behavioral Health, and Emily Lindeman, who works at MDH in the Injury and Violence Prevention section as a suicide prevention coordinator. Next slide. Before we get started, let's cover a few webinar reminders, stroke program updates, and today's objectives. Today's webinar is being recorded for future viewing. Your lines have been muted upon entry. Unless you are presenting, please keep your line muted. You can interact with our presenters today using the WebEx features. Share a reaction by clicking on the smiley face for emoji options, or ask questions by typing them in the chat throughout the presentation, and make sure to select everyone in the chat box. We will keep track of these questions and we'll try to address them at the end of the presentation or within the webinar follow-up email. Next slide. We will not be hosting a monthly webinar in June or July as we finish reapplying for the Paul Coverdell National Acute Program funding. We hope you enjoy your summer breaks and vacations during this time as well. We look forward to connecting with those who can make it tomorrow at our Stroke Coordinator half-day workshop in Brooklyn Center. Doors will open at 8:30 a.m. with a light breakfast and coffee available. And just a reminder that we will be hosting our final Coffee Talk session with Chris Kleckner on May 28th at 10 a.m. Chris will be talking about how education and health literacy impact healthcare disparities and wrapping up discussions from our Coffee Talk series. We will be sending out an evaluation for those that participated in the series following that session. Next slide. For today's agenda, we will cover how to identify signs of depression in patients following a stroke and services available through the 988 Suicide and Crisis Lifeline. Upon completion of today's webinar, you should be able to assess stroke patients for depression and anxiety, recognize signs and symptoms and the impact on relationships in post-stroke patients, and describe mental health treatment and services for post-stroke patients and caregivers. Now, I am happy to turn it over to Dr. Greenberg and welcome him into today's important topic of mental health after a stroke.
Good morning. Thank you for having me and inviting me to this. So I'm a health psychologist over at Park Nicollet in the physical medicine rehab department, and I work primarily with patients who have a combination of mental health and physical health issues, including stroke, TBI, things like that. In terms of today, I was hoping that we could go over who is typically affected by depression and anxiety after stroke, go over a little bit of descriptions of what each of those look like in general, and then specific with strokes, and then go over some options for assessment and treatment. Next slide, please. So when we look at stroke, we're seeing hundreds of thousands of new cases per year. And of those, about 1 in 3 people experiences depression, and about 1 in 5 has anxiety. It's important that we're assessing for this, as it can impact not just emotional functioning and somebody's satisfaction with life, but also other health outcomes, such as risk of dementia, heart disease, mortality, etc. Next slide, please. So we're seeing higher rates of depression in stroke, depending on the severity of disability after the stroke. In particular, somebody's functioning about 3 months to 6 months after a stroke is where it can really start setting in, and you see a spike in depression. If somebody is unable to return to work or their major leisure activities, that could be another major predictor of depression. Otherwise, a history of depression prior to the stroke, being younger, being female, having a lack of social support, lower education attainment, having a non-white or Asian ethnicity, all those can impact increased rates of depression. The ethnic factors are mainly related to sociodemographic variables, such as available resources, financial insecurity, things like that. For anxiety, there's less of a confluence of factors, and it's more if somebody has anxiety prior to a stroke, they're likely to have it afterwards as well. In addition, even though it may not reach the level to be diagnosed, about 15 to 23% of people do experience some subclinical symptoms as well. Next slide, please. Looking at a timeline following stroke, it is extremely normal to have some level of depression within the first few days after a stroke. But frequently, this initial burst of depression does reduce over time, and it shouldn't be treated prophylactically. So if people are not experiencing treatment symptoms, they shouldn't be prescribed antidepressants, as this can increase risk of side effects like some mental confusion, fatigue, increased rate of falls, fractures. It's a low risk, about 1 to 4% increase rate, but it's still, if somebody's not going to develop depression, it's not something appropriate to treat. When you're looking at the 3-month to 1 year time frame, you tend to see that people who are not initially depressed do develop it, and it tends to be fairly stable, where people who are depressed at 3 months in tend to still be depressed a year later. This does improve a bit over time, as about 2 years after the stroke, the number of people who are affected by depression drops from about 1 in 3 to about 1 in 5 instead. Next slide, please. So when we're looking at depression and anxiety, it can be kind of helpful comparing it to where somebody is in the present. So when they're thinking more about the past, regrets, things they wish would have been different, they're more likely to experience depression. And if they're more focused on the future and fears of what could possibly happen, it tends to show up more as anxiety. Next slide. When I look at assessing for depression or anxiety, I find it really helpful to look at it in 4 different parts of a person's life. So looking at emotional, physical, mental or cognitive, and then social or behavioral symptoms. With stroke and depression or anxiety, you tend to see more physical and mental symptoms in general, which can kind of confuse diagnosis of depression and anxiety. So it really has to be a unique experience, and trying to focus on what is separate for patients from the stroke that is a mental health symptom. So I might hear somebody say that they don't have hope for the future. It's usually a good sign of depression and anxiety. Or my spouse stopped doing all of the things that they used to do for fun and now holes up in their room all the time. Some of those social factors. Next slide. When we're thinking about depression, a really common challenge with it is a negative comparison of yourself to the past and making unhelpful comparisons. So if somebody's looking at their highest level of functioning before the stroke and comparing themselves to that, it's likely that they dismiss any of the gains and progress that they've made. Whereas if they look at themselves at their lowest level of functioning after the stroke and the progress they've made since then, they're most likely to do quite a bit better. There's this quote I love that if you're going to climb a mountain, do it backwards. That way you don't see how far you still have to go, but only how far you've come. And that's really the main idea of this. Next slide. With anxiety, I tend to look at it in terms of a 2-step process, where the first step is identification that something is dangerous and can potentially cause harm physically, financially, emotionally. Something bad is going to happen. With a stroke, it's hard to minimize the perceived danger of that. So instead, focusing more on the second step of, can I handle it if this dangerous thing happens? And building up someone's self-efficacy, reminding them of how they've dealt with challenging situations in the past, or who are their available supports, what are treatment options. The goal is to increase their self-confidence. So by feeling more confident, there's less anxiety present. One of the lines I love with this is from A. Milne with Winnie the Pooh, where it's you are braver than you believe, stronger than you seem, and smarter than you think. And being able to remind people that they're more than they give themselves credit for can really help out. Next slide. Another thing with anxiety is that it is wonderful at asking questions and absolutely terrible at answering them. So there's a lot of different unknowns involved with having a stroke, but being able to come up with some general positive answers to those questions and treating them as if they were actual questions can lower that fear of the unknown. Next slide. Another piece that I find really helpful to consider is looking at stroke as an impact on the entire system surrounding a patient. Spouses, families, friends, things like that. A challenge is there can be reciprocal caregiving with loved ones, where someone with a stroke may minimize their own symptoms to try to take care of others. And likewise, there can be caregiver fatigue, which contributes to conflict, frustration with somebody who's still trying to recover from a stroke. Um, there's a line I love from the movie Murder Ball, back over 20 years ago, uh, talking about a relationship with yourself and how people are still themselves following an injury or stroke, in which one of the people's friends said, yes, he was a jerk before the accident and he's a jerk afterwards. And it's a little tongue in cheek, but the idea that even with a stroke, people are still themselves. They care about the same things. And yes, it's expressed in a new way. There is a new normal, but having a hold on that personal identity can help preserve that relationship with yourself. Next slide. Oh, next slide after that. There we go. When we look at different challenges or pitfalls with strokes, one of the things that can be useful is focusing on what you do not see better explained by stroke symptoms. So with a stroke, if somebody has aphasia, cognitive interference, difficulty with mobility, looking at expression of emotions and looking at engagement in pleasurable activities can be more useful. The challenge with that is if you're looking at your middle-aged Midwestern man as a stereotype, where there's more difficulty with emotional expression and cultural factors limiting expression. One of the things that can be really helpful is meeting people where they're at. So if they talk about missing a leisure activity, going with that. If they're focused on recovering for a specific purpose, it's however they conceptualize it themselves. Next slide. There are a variety of pretty common assessment measures for anxiety and depression. Uh, the two that I like the best are the geriatric depression scale or the hospital anxiety and depression scale. Some of the other ones I find ask too many questions about somatic symptoms, which you can get a false positive because of stroke symptoms. And the two of these tend not to be too long and kind of get more at the heart of the emotional impact of a stroke. Next slide. When we're looking at treatment, about a third to two-thirds of people after a stroke are not receiving any form of treatment for mental health symptoms. There are a variety of factors related to this, such as patients being older, male, having non-white, Hispanic, or Black ethnicity, and lower sociodemographic status. Some of these can be related to personal factors not identifying depression. So with age and sex, older age and male sex have lower rates of depression in the first place, so they would have lower rates of treatment. In contrast, lower sociodemographic status and the ethnic factors and sociodemographic factors have higher rates of depression but lower treatment, and that's more related to access. Next slide. When we're looking at treatment, it's always great to start with what somebody already has available. So if they have available social support with friends, families, other stroke survivors, making sure you're utilizing that and asking questions about what people have already tried to help manage their mood. In terms of medications, SSRIs are the frontline treatment. They tend to have pretty low risk of side effects, um, so that tends to be the go-to. For therapy, there's a variety of options: cognitive behavioral therapy, acceptance and commitment therapy, mindfulness-based stress reduction. All of those are effective. There's probably the strongest evidence base for cognitive behavioral therapy, but any of these can work beautifully depending on the patient. For complementary and alternative treatments, it's more mixed evidence for them, and it can be personal interest in what a patient finds beneficial. So anecdotal evidence and personal beliefs really play into that. There's not a lot of good evidence for non-invasive brain stimulation, as that's a more modern treatment. So that tends to be less of a priority. In general, combining medication and therapy is more effective than either one alone. Next slide. And finally, looking at what are some mental health factors that help with resilience. Um, in my experience, the patients who do best are the ones who say something along the lines of, I wouldn't wish this on my worst enemy, but I'm glad it happened because it allowed me to slow down. It allowed me to prioritize relationships that were most important to me. People who develop new beneficial emotions about the stroke. I had a gentleman who was going to a reunion and was anxious what people would thought of him. And we talked through how he could use a sense of humor, pretending that he was worse off than he was to get people to laugh when he pulled a gotcha on them, or expressing gratitude towards people who care for them. It can also be beneficial finding new meaning and purpose in life. Yes, this has been a change, but if you're going to lose something from a stroke, what can you gain back from it to make it a trade? So next slide. I realize that was an incredibly quick overview with a lot of scattershot information. Hopefully it was helpful to hear some things that I look at in terms of trying to assess and treat depression and anxiety following stroke. If you do have any questions, please feel free to type them out or let me know at the end. So I really appreciate the invitation. Thank you. And next slide for the closing one.
Thank you, Dr. Greenberg. I will now pass it over to Emily Lindeman to talk about the 988 Suicide and Crisis Lifeline.
Thanks, Jamie. So like Jamie said, I'm a suicide prevention coordinator with MDH, and our team works on providing statewide coordination of the Lifeline in Minnesota. So I'll just provide a really quick, really high level overview about what is the Lifeline, how to get connected to it, and ways that you can help share the resources. So next slide. So if you've heard of the National Suicide Prevention Lifeline, it has now officially transitioned over into the 988 Suicide and Crisis Lifeline. 988 is a new short dialing code that anyone could either call or text to in order to reach the Lifeline. It's not a new service, it's a new number, it's a new way to connect, but it builds upon the foundation of the previous National Suicide Prevention Lifeline. So right now, regardless of whether you call 1-800-273-8255 or if you dial 988, you'll still get the same service. 988 is available in all US states and territories. It's a national program that is partially funded by the federal government, but it is local services. So there are designated centers in Minnesota who are answering calls, chats, and texts that are coming in. Next slide, please. So 988 is a distinct crisis services. They operate 24/7. They're confidential, they're free, they provide listening and support to anyone who calls. They're also able to provide information and resources to local communities. So someone might be calling in because they're distressed or they're experiencing food insecurity. 988 could help provide them with information about here are some local food pantries in your area, or here are some services that you could access. And then they're also able to provide some of that crisis intervention for help seekers as well. Um, a lot of people also do call 988 because they're worried about someone and they're not sure how to talk to someone or how to bring up whether or not someone's having thoughts of suicide. So it is also a place where you can receive some information or education about helping supporting someone that you're concerned about. Next slide. So one of the things that I do want to emphasize about 988 is that it is not a response service. So 988 does not provide any response in person to people who are reaching out to the Lifeline. The service that 988 provides is that interaction, that conversation and dialogue with a crisis specialist. If it's determined on a 988 during a 988 conversation that a person does need some type of in-person response, 988 can facilitate that transfer and help connect that person to the most appropriate resource. So it's not meant to replace local mobile crisis teams or crisis services that are out there. It's not meant to replace 911 emergency services or other dedicated lines. It's just another option for people to call and make that connection if they're in need of support. Next slide, please. So one of the most common ways that people connect to the Lifeline is by calling. You can simply dial 988. There is third-party interpretation services that are available 24/7. The Lifeline centers do not receive any information about where a caller is calling from. They're able to see the phone number, but they don't know if you're calling from St. Paul versus St. Cloud. So when you do dial 988, if you want to bypass the greeting, you'll press 0 and that will connect you to a crisis specialist a little bit more quickly. You can press 1 if you want to be connected to the Veterans Crisis Line. If you press 2, you'll be connected to the Spanish language network of 988. And then if you press 3, you'll be connected to the LGBTQI plus network, which specializes in supporting youth and young adults under the age of 25. 988 does require that a person has active phone service in order to make that call or connection to the Lifeline. Next slide. The other common way is to text in to the Lifeline. Any mobile device that is able to send and receive text, you're able to connect. Again, you do have to have active phone service and your location information isn't shared. They're just able to see your phone number. And then there are specialized services that are available. So if you're a veteran, current service member, or family member, you can text to 838255. For Spanish, you can text Ayuda to 988. And then for that LGBTQ youth and young adults service, you can text Pride to 988, and that will get you connected to specialized specialists who primarily focus on supporting those communities. Next slide, please. So the third way to connect is through online chat. So if you go to 988lifeline.org, you can chat via a web browser with a crisis specialist. It's routed based off of area code or zip code. So you'll, before you are connected, it'll ask you to fill out some information and it'll ask for a zip code. And so Minnesota zip codes would be routed to our Minnesota Lifeline centers. And again, there's specialized services for veterans, Spanish, and LGBTQI plus youth. The newest service available is that American Sign Language is also an option. So again, if you go to that 988lifeline.org, you could be connected that way for ASL. Next slide, please. All right, so what happens when someone connects to 988? Typically, every person who calls is screened for suicidal risk, and that kind of helps determine where that call goes next. So, based off of the severity of the risk, um, the 988 Lifeline specialist may offer to connect the help seeker to mobile crisis services. If a medical emergency happens during the call, they can connect them to 911. They also do a lot of safety planning. So crisis specialists actively work with the caller or the help seeker to develop a safety plan of, what are some coping strategies that you could use? Are there people in your lives that you can lean on or connect to if you need extra support? And then they're able to provide that information and referral to local supports if the person is looking for some of that information. And then 988 is also able to offer some limited follow-up services. So typically at the end of a call, if a person says, the crisis specialist might say, hey, do you want me to give you a call back in like a day or two and just check in to see how you're doing? If the person says, yes, I'd like that, then they'll take their information and do that follow-up call. Next slide. So this is just some stats from 2023. Minnesota does have 5 Lifeline centers that are designated to answer calls, chats, and texts 24/7. So last year we saw a 74% increase in the number of contacts that were coming in. I won't go through all of this, but I do have a link to our summary if you're interested in reading the full report. I think it's just 2 pages. Next slide. And then the one thing I just wanted to just emphasize here, what you could do, I always encourage people to engage with their local partners and discuss how your community might use 988, how that might work in what your current protocols are. I also really encourage people to reach out and kind of think about how your 988 center, how 988 might work with your local mobile crisis team or other services that are already available, and just to kind of build some of those connections. Next slide. And then the last thing I just wanted to say is that we are asking everybody to phase out the 1-800 number and really just start using the 988 number to promote the Lifeline. I have different resources on here that you can, if you're looking for the logo, if you're looking for different resources or printable materials, those 3 links will take you to a variety of different options that you have. And then you can go to the next slide. I know that was, again, a really quick overview, but you're welcome to email us with any questions and happy to provide any information that might be helpful for you. So thank you all. I'll turn it back over to you, Jamie.
Thank you so much, Emily and Dr. Greenberg. A lot of great information you presented on. We now have a couple minutes for some questions, so please use the chat feature, or raise your hand and unmute your lines to share any final comments or questions. It looks like we have a question for Dr. Greenberg in the chat. At the time of hospital discharge, stroke patients are often overwhelmed, not only with the multitude of life changes, but also with the magnitude of information being conveyed to them. What do you suggest should be conveyed to patients and their families regarding depression and anxiety at that time, or is it better left to those in an outpatient setting?
So I would completely agree. There is a lot of changes and information coming at that time. So I would say keeping it pretty basic and simple. What I would find most helpful is normalize that This is a lot of changes. It's normal to adjust to them. If you find that they're continuing and getting worse in the future, that would be a sign to seek out extra treatment. Like giving them some warning signs of here's reasons that you would need to seek treatment immediately. So if people are endorsing suicidal ideation, don't pass go, collect $200, go straight in and try to get treated right away. Otherwise, just uh, normalizing that, yeah, this is going to be a lot of changes and encouraging them to identify who they could reach out to connect them with additional outpatient services.
Thank you. And it is 12:30, so we will wrap up now. If you have any further questions, go ahead and email the presenters, or you can email the stroke email as well. You can scan the QR code with your phone that will direct you to the survey for the contact hours, or you can click the survey link in the chat. Upon completion of the evaluation, you will receive 0.50 contact hours for today's webinar. If you are watching the YouTube replay, please scan the QR code or expand the description box and click on the survey link for your contact hour. Before we close, I would like to extend a very warm thank you to Dr. Greenberg and Emily Lindeman for sharing valuable resources on mental health. To everyone else joining today, thanks for all you do. And as a reminder, we will not have the regular scheduled webinar in the months of June or July. Thanks again, everyone, and enjoy your summers.